Assalamu alaikum. I'm Dr. Osama Azhar. I will be presenting my presentation on topic comparing two different salts of SGLT2 inhibitor drugs in fasting diabetics. This study has been conducted under kind supervision of Dr. Muhammad Imran Hassan Khan, and my co-authors were Dr. Salman Shakil, Dr. Faika Ijaz Khan, and Dr. Aksam Javed. So, the background of our study was that Ramzan is a holy month coming once in a year and carries a lot of religious attachment for Muslims. Majority of the Muslims want to fast in it, leaving all the advice of their physicians behind. SGLT2 drugs were all available in the West for a long time, but they are present for Pakistani populations since last month, Ramzan. The aims and objectives of our study were to assess the risk of hypoglycemia in fasting diabetics using two different salts of SGLT2 drugs available in Pakistan that were dapagliflozin and empagliflozin and compare them. To check for the change in HbA1c levels and eGFR levels in both groups, to collect evidence to recommend use of these drugs in fasting diabetics. The materials and methodology of our study was we collected data from 5,500 patients from 3 different sites, and out of these patients, only 279 fulfilled the criteria for inclusion. Pregnant, lactating women, advanced chronic kidney disease, and comorbidly ill patients were not included in our study and were excluded. Data was analyzed using SPSS version 23, and chi-square test was applied as a test of significance. The inclusion criteria of our study was all patients who were already taking medicine for at least 3 months. No new patients were added. Patients were advised to continue taking metformin and DPP-4 inhibitors if they were taking before induction in our study, and HbA1c levels between 7 to 11. The study design of our research project was, it was an open label study. It had 2 arms, one arm involving the dapagliflozin group and the other involving empagliflozin. It was a randomized trial, parallel study over 12 weeks. Data collection started 4 weeks before Ramzan, continued during Ramzan, and ended 4 weeks after Ramzan at the time of new HbA1c levels. The duration of our study was from April 2019 to July 2019, and June 2019 was a period during which Ramzan occurred last year. So the results of our study, comparing the age groups, we can see that in the dapagliflozin group, less than 30 years of age, there was no population whose age was less than 30 years, and only 3% of the population in empagliflozin group was less than 3%. Majority of our population was in age group of 30 to 50, with the dapagliflozin having population of 76.4% and empagliflozin having population of 75.10%. And similarly, greater than 50 years of population was almost equal in both the groups. The gender distribution of our study was the majority of the population, male population, was in the empagliflozin group, and in the female population was in the dapagliflozin group. The average BMI for population, there was no candidate patient in our study who was underweight. The patients who had normal BMI were more in the empagliflozin. Similarly, the empagliflozin group had more overweight population. The largest population were obese, and they were almost equal in both in and empagliflozin group. Similarly, the majority of population in relation to hypertension in our population was normal in both the groups, followed by pre-hypertensive patients, then those who had stage 1 hypertension, then those having stage 2 hypertension, and almost least number of patients had stage 3 hypertension. When we compare duration of diabetes in both the groups, the patients who had less than 5 years duration of diabetes were more in the empagliflozin group. Those having duration of 5 to 10 years were more in that dapagliflozin group, in contrast to those having less than 5 years duration who were more in the empagliflozin group, but those who had greater than 10 years duration were more in the empagliflozin group. Comparing the comorbidities in both the groups, you can see that those having dyslipidemia in the dapagliflozin group were 40%, 50% of the population had retinopathy, 27% population had neuropathy, 23% of the population had nephropathy. CVA was not significant; it was only 1.8% of the patient of the population who had CVA. Similarly, CVD was 0.9%, and peripheral vascular disease was 13.6% of the dapagliflozin group. No, we can look into the empagliflozin group, where 24.9% of the population had dyslipidemia, 51.5% of the population had retinopathy, 36.1% of the population had neuropathy. Nephropathy was 14.8%, 1.2% CVM, 2.40% CVD, and 25% of the population had peripheral vascular disease in empagliflozin group. By comparing both the groups, we can see that mm, the retinopathy was the greatest complication in both the groups. Now, comparing the pre-Ramzan and post-Ramzan GFR levels, the CKD stage 1 patients were more in the empagliflozin group. CKD stage 2 patients were more in the dapagliflozin group. CKD stage 3 A patients were almost equal in both the groups. Similarly, CKD stage 3B patients were all in the dapagliflozin group. There was no patients who had CKD stage 3B in empagliflozin group. And there were no patients with CKD stage 4 and stage 5 in both the groups. No, when their GFR levels were calculated after Ramadan, the patients who had CKD stage 1 decreased significantly as compared to those patients who had CKD stage 1 before Ramadan. Similarly, in CKD stage 2, the number of patients increased in relatively to pre-Ramzan levels. CKD stage 3 patients also increased in number as compared to pre-Ramzan levels, and CKD stage 3B patients were almost equivalent in both the groups. Similarly, there were no patients who had CKD stage 4 and stage 5 post-Ramzan also. When comparing the pre-Ramzan HbA1c levels and post-Ramzan HbA1c levels, we came to know that the patients who had HbA1c levels between 6.5 and to 7.5 were almost equivalent in both the groups. Those who had between 7.5 to 9 were more in the dapagliflozin group, and those having greater than 9 were highest in number, with more in the empagliflozin group. Uh, Similarly, their post-Ramzan HbA1c level results show that the number of patients who had HbA1c levels between 6.5 to 7.5 decreased in comparison to pre-Ramzan levels. It was only 11.3 in the pegliflozin group, but increased in a pegliflozin group with 21% of the population in comparison to 15% of the population in pre-Ramzan levels. The patients who had HbA1c levels between 7.5 to 9 also increased in number, but the patients who had HbA1c levels greater than 9 decreased comparatively as in relation to pre-Ramzan HbA1c levels. We had a questionnaire regarding their knowledge and attitude about hypoglycemia, which showed that the patients who experienced events of hypoglycemia were more in the dapagliflozin group before Ramadan. Those who had symptomatic hypoglycemia were more in the empagliflozin group. Those who checked BSR level during event of hypoglycemia were more in the empagliflozin group, and those who were able to treat during event of hypoglycemia were more in the empagliflozin group. Uh, Similarly, those who required assistance or admission were almost equal in number, and those who can treat low BSR without symptoms were almost equal. And the patients who documented low BSR without symptoms were more in the empagliflozin group. We can see here those patients who experienced events of hypoglycemia during Ramadan were more in the empagliflozin group, and those who had symptomatic hypoglycemia were more in the dapagliflozin group. Those who checked BSR level during event of hypoglycemia significantly increased in number in the empagliflozin group, and in the dapagliflozin group they remained constant. Those who were able to treat during the event of hypoglycemia were also more in the empagliflozin group. Those who required assistance for admission during event of hypoglycemia were 0% in both the groups, and those who documented low BSR without symptoms were almost negligible. And similarly, when you compare data regarding those who felt more thirst during fast were significantly high in number in the pegliflozin group, with only 7.3% population in the pegliflozin group, and those who felt bitter taste in mouth during fast were also more in the pegliflozin group. So comparing the results after Ramadan, we came to know that those who experienced events of hypoglycemia were almost equal in both the populations. Those who experienced symptomatic hypoglycemia were also almost equivalent. Those who checked BSR level during event of hypoglycemia were more in the empagliflozin group. and those who were able to treat during event of hypoglycemia were almost equivalent in both the groups. And those requiring assistance or admission during event of hypoglycemia decreased in the dapagliflozin group as compared to pre-Ramadan and during Ramadan levels, but they were almost remain constant in the empagliflozin group. Those who treated low BSR without symptoms were more in the dapagliflozin group. The patients who documented low BSR without symptoms after Ramadan were more in the empagliflozin group as compared to in the dapagliflozin group, as is evident in this graph. From this study, we concluded that the EGFR was better with the empagliflozin group with duration of diabetes having less than 5 years. HbA1c was decreased more with the empagliflozin group. There was more thirst experienced in empagliflozin group, as was bitter taste. Hypoglycemia was more frequent before and after Ramadan with the empagliflozin group and more common with empagliflozin during Ramadan. We concluded that both SGLT2 drugs were safe during Ramadan, with each having their own merits and demerits. There were some limitations of our study. Two arms of SGLT2 were not equal. Better was to have equal groups. Study group was small. Dapagliflozin and empagliflozin of different brands were used, which might have affected our results.